Try one more time. Okay. Do you guys give me a thumbs up if you see the recording thing in the top corner? I can't see it on mine. Yeah, okay, thanks, Taryn. All right, let's shake and bake. Please do read the slides before this. They talk about myths that can be dispelled about behavioral emergencies, and they're very important. Some of those we'll address in the process of doing this. So a behavioral crisis is when somebody's response to external stimuli is inappropriate, right? Like that's a very easy definition to say that we don't need a whole lot of information to understand that. So a behavioral crisis is often somebody responding to something, some stimuli, in a way that's not always logical. It's maybe exaggerated in the case of somebody who's perhaps going through a manic state. So maybe they're very depressed when others would be, deflated, maybe not fully depressed. And they're very happy and rambunctious when others would be, like we are today, pretty happy, normal. This person would respond in a particular case that I'm thinking of, they would respond kind of in larger amounts or respond just completely inappropriately. When others are laughing, maybe they're crying. And there's a lot of nuances in the number of different behavioral crises and behavioral diseases that people have. And they're they fit a framework, but every person's likely to experience their behavioral crisis differently. So though we may have seen something similar, let's say that you're now recognizing that a patient before you is having a bipolar breakthrough, right? So they have bipolar disease, and you've had other patients that are bipolar that have had breakthroughs before. Don't just assume that this person's going to follow all of those steps. The world they're living in when they have the break from reality is not the same world that we're living in. Another example, I'm sure that in the past you've heard of individuals that, and this is just layman's stuff for sure, but it's a physical condition. You've heard of individuals who maybe were being apprehended by law enforcement, and while they were trying to control this person exhibited superhuman strength. There's been cases when, kind of little people, as far as like height and weight, kind of petite people, have overpowered 3 or 4 police officers and or firefighters in the means. And not all firefighters or police officers are big and burly, but we are pretty strong because of the nature of our work. So in those cases, those individuals, this often comes about because of something called excited delirium and because of medications or drug abuse. One that I'm thinking of is folks that do PCP or angel dust. Some of those folks think they can fly. They think they're superhuman. And in fact, there's been cases where people have been shot by law enforcement multiple times in the torso, though not in the head. If it was a headshot, it probably would end the process. But even though they've been shot multiple times, it seems to unfazed, they're not fazed by it, and they keep charging the police officer until literally all the blood is out of their blood vessels. Now that can happen because in their world, that dissociation with reality is broken. So there's a lot of variance in between. People generally do, if they have a psychological disorder, and I don't think these are all great ways to say it, because I'm not sure that somebody who has a behavioral condition has a disorder. I don't think that's a good word to use, but you understand. So a lot of times they'll understand how to deal with their disease, and they have breakthroughs. So many behavioral crises are actual breakthroughs of their underlying disease, which may be controlled or they don't even know they have yet because they haven't been diagnosed. So when we have patients that are responding to that stimuli, stress is something that we need to take into account, give an adrenaline dump. So you're expecting sympathetic nervous system is the predominant effect here. When that stress is not managed, it turns into a crisis. And that's true for a lot of different things in our lives, not just behavioral emergencies. So when somebody has a behavioral emergency, and we can call it by a few different names, psychiatric, psychological, mental, whatever it is, we're talking about people that, again, are not responding appropriately to stimuli, and they're overly responding in many cases, which means that they may be putting yours and other people's lives at risk. So when I say something like excited delirium, let me define that for us real quick. Delirium is a condition. It's like a symptom in some ways because many drugs and many disorders cause it. But delirium is a case in which the person has a break from reality. That's the delirium part. And they're very agitated and they have a huge adrenaline dump that doesn't seem to end very easily. So we're going to watch a video in a minute about how that can get us into some legal trouble in many cases, even though it's a a video about a paramedic's treatment, it still rings true for all levels. So these patients often can be very agitated, very excited, very charged, right? They've got tons of adrenaline going through their body, and they can often be violent. Now, it's unfortunate, but it is the case that many people will see EMS, fire, as an authority like law enforcement. And so just because we're not cops when we go to a scene doesn't mean that they're going to think of us in a different category. So many people think of us in the same category as law enforcement, lots of reasons for that. But that means that people who would not necessarily assault a healthcare worker might assault us if they kind of put us into the box of law enforcement. In the state of New Mexico, every state's a little bit different. There is a law that protects us, in which if a healthcare worker that's in the process of doing their work for somebody is assaulted, New Mexico has raised that to a 4th-degree felony. And that's a big step for us. It requires us to report it. But we do find that some people that abuse EMS in the sense of calling frequently also physically and verbally abuse us. And so if you're assaulted, if you're battered by a patient, please, after the situation is remedied and safe, consider bringing about those charges. Because if you let it go, maybe you got through this unharmed. But if we don't put a stop to it in that person's mind through maybe the effect of law, then maybe the next time they assault an EMS provider because they didn't learn not to do it, they go too far and actually harm or kill that provider. So it's an obligation for our team to make sure that we address this very, very clearly and quickly. How would you do that? Law enforcement to the scene if they're not already there, and talk to them about the healthcare provision protecting us from assault. Now, there's a lot of terms we're going to talk about for symptoms of behavioral crises. We'll get into them in a moment. But when we're talking about dementia or depression, those are not the same as delirium. Delirium is, again, break with reality. Depression and dementia often have things of lack of memory for dementia. And depression is not necessarily a break of reality. It's just an overwhelming, and I'm sure we've all experienced this, an overwhelming feeling of being depressed, of losing kind of that zest or the happiness in our life. And there's lots of reasons for depression to come up. When it's a problem, because we're all going to be depressed at some point in our life, transiently, temporarily. When it becomes a problem, though, it's when the depression goes on for too long and starts interfering with somebody's daily activities. And so ADL, make a note of that, ADL. ADL stands for activities of daily living. And so those are a measure to make sure patients are, mentally, psychologically, and in their socioeconomic sitting, they have everything that they need. So that means that you would, if you're concerned about somebody not doing the basic things of life because of depression, then you're going to investigate things like, how often are you bathing? How often are you eating? Look at their home. Does it look like the home, is a hoarder's home, or is there no food in the refrigerator, right? Not doing activities of daily living, like washing dishes, cleaning, caring for yourself with hygiene, those can be indicators that this person is experiencing a behavioral emergency, though it may not be rambunctious and really excited. It's the complete opposite, the polar opposite of depression. So chronic depression is essentially persistent feeling of despair and sadness. Now, when a patient is presented with us, not all psychologic patients or behavioral crisis patients are going to be violent, as mentioned. So we really want to make sure that if the patient is showing violence or showing threats, we think of scene safety. We try to evacuate ourselves and anyone that we can safely get out of that area. That's our first choice. Our first choice is to retreat and let someone else, who we call law enforcement, let someone else manage settling that person down. Now, I say that as a goal, but I could tell you with lots of experience in this, unfortunately, I've worked in areas where law enforcement's 2 to 3 hours away. You may be in a position where you'll have to fight, and sometimes that fight might be the fight for your life. Okay, so you don't want to initiate the fight. Don't initiate the fight. Let that person, with your verbal judo, by talking to them patiently, calmly, not giving in to some of their dissociative realities, not giving in to their demands necessarily, trying to get them to calm down so we can safely get through this verbally, that's appropriate. But if you're physically managing this patient, You're at risk of harming them, which is completely your fault when it comes to the word of the law, because you're supposed to have control over the scene. Even if the person's going a little crazy, a lot crazy, whatever it is, if they're harmed in the process of you trying to restrain them, that's likely going to be a lawsuit. You may not lose, but it'll probably be a lawsuit in this day and age. And it's probably on video as well. Now that folks take medical situations, traumatic emergencies, when EMS is called, and record those as they do with law enforcement. Okay. Now, a person, if they're a threat to others, clearly that's a situation for concern, but it still is a concern when they're a threat to themselves. We have the obligation of trying to prevent that person from harming themselves. Again, we can't put our life in danger to do so, because if we're injured, remember what happens to the team. If somebody on your team is injured and they're not the patient, all the resources are going to go to the EMT, the firefighter, whoever's on our team that's injured, and the people that we were initially called for will become second. And a lot of times we'll let our guard down. And in responding to help the person that's fallen, we'll let our guard down as far as security on the person that perhaps is running around with this until subdued. Okay, so a few things on scene safety. This is a reminder. Again, this is stuff that you read earlier in the term. When we're retreating from an environment, or a few things like in the environment, if you're in a building, if you're in an enclosed space, you always, as soon as you walk in that room, and probably before you go in the house or the building, you need to take a moment to look at all the exits. Okay, take stock of where does that door go. Maybe you can't walk to the back of the building, but if you can, maybe do so before you ring the bell, because you want to know, does that door in the back go to a very vicious dog, making it a hard escape route for you. When you go into the home, the first thing that you should be doing is not getting information on the patient, but assessing the environment and making sure that you know what's in between you and escaping if stuff goes down. And again, this is every call. This isn't for behavioral emergencies. Every call you should be doing this, because we often don't know when this stuff's going to come about. It comes about and surprises us, unfortunately. So as mentioned earlier, never let someone become between you and an exit. Okay, you should have your back to that exit at all times that it's possible, and never let anyone, even if they look like you could take them physically, like they're smaller than you, or you feel like you've got a lot of energy, or you're a MMA trained fighter, any of those things doesn't matter. Don't take someone for granted. So please don't let somebody get between you and an exit. If you do, you're going to have to find another exit to survive this. Okay. Also, look for signs that people are becoming agitated and indicators of violence. You can find that on YouTube. Plenty of videos of indicators of violence, but they include things like, obviously, somebody physically distressed about something. They're going to clench their fists often. They pace a lot while they're trying to decide whether or not they're going to bring violence about you. It's like a really interesting psychological process, and you can see that on YouTube. So look for those signs, and as soon as you see them, start to diffuse the situation verbally or retreat. Again, we intend to go back when the scene is rendered safe. And if obviously you have law enforcement available before a call, and you know that this call is likely to have some violence by the dispatch information, don't park in front of their house while you wait for law enforcement to get there to clear the scene for you. Okay. When we either go to the scene and we're on standby for law enforcement, we should be parking a block or two away, out of the line of sight of the home. You shouldn't be able to see the home, because if you can see it, they can see you. And they're going to be angry that you didn't just go to their house, even though anyone looking at the situation externally would say, oh yeah, police should go there to secure it first. You want to make sure that the person thinking emotionally and in anger doesn't get angry that you were standing by. Okay. When you retreat, do the same thing. Leave, get out of there, and go somewhere where they can't physically see you. Okay. Next step is to know that there's two types of protection you have. One is concealment, the other is cover. Okay. So concealment just means that they can't see you, but it doesn't mean that you have a physical barrier to stop any projectiles like bullets between you and that person. So when we talk about cover, that means that it's a physical barrier between you and that person. And generally, cover is almost always concealment as well, unless you're hiding behind bulletproof glass that they can see you through. Okay, so if you're running out of a house and you're trying to, you're retreating, you're trying to get away from somebody who's an attacker, you wouldn't want to, if they have a gun, you wouldn't want to hide behind a bush, because maybe they can't see you behind the bush, but if they fire in the bush's general direction, you have no protection. Okay, so know the difference between concealment and cover. The first area of cover that's like a safe spot for you might be the ambulance. Unfortunately, that's not always a great idea. We responded to a call in the mountains once, and it was 3 of us on that truck just because we had a ride along that day. It was somebody who wanted to work with us, who already had a license. Thank goodness. I don't know how it would have gone without him. Went into a house where somebody was complaining of chest pain and like 32, and the male 32-year-old chest pain. That's not usually a heart attack. It could be, but it's not usually a heart attack. So we're thinking of other things. Didn't necessarily think of the idea that they're having chest pain because they did a whole bunch of cocaine. When we walked into the home, not knowing any of this, we immediately recognized that this person is having a break in reality. He's basically got excited delirium. And as soon as we walk in, already my eyes are trained to find potential weapons, and they're everywhere. There's a box cutter sitting on the table, in the coffee table in the living room for whatever reason. There's a sword that's mounted above the fireplace, like a literal sword. All those things and other things that aren't necessarily traditionally weapons can turn into a weapon. So we retreated. Unfortunately, the ambulance was parked right in front of his door. So when we retreated, we got in the ambulance and we tried to leave, and the ambulance had broken down when we pulled in. So it wouldn't start. So we had to retreat on the other side of the ambulance, call for law enforcement, which took 45 minutes to arrive. We didn't wait for them to arrive to remedy the situation, but what we did is going to be similar to what you're going to see here, although morally it was appropriate to do so. The video we're going to see isn't. All right. So it's not always safe. All right. So some generalized anxiety disorders can include panic disorders, social and other phobias. Phobias will fall into the anxiety domain of disorders. PTSD, obsessive compulsive disorder. A lot of these things share similar components, though on their face maybe you wouldn't necessarily see. For example, in PTSD, many folks that have PTSD have an obsessive compulsive component in which they chronically avoid something, or they chronically do something that isn't necessary, but they're doing so because of their post-traumatic stress. All right, I'll let you guys read about that. So some of the other things that can cause these disorders or underlying causes can include social and situational stresses, especially if somebody has something that's really big in their life that's going the wrong way, right? That's producing stress. So a divorce, loss of a job, death of somebody is likely to bring about a break in reality. Underlying diseases like schizophrenia, which we'll see in a moment, bipolar disorder, physical illnesses can change your mental state, right? So a patient that is having a diabetic emergency, AKA hypoglycemia, that person is not going to be thinking appropriately. And so when patients don't have enough sugar for their brain to work or enough oxygen, it's common that they go down kind of we could say, anticipated route. So let me see if I can write down the order of how the LOC falls apart. All right, so let's see, this is going to be like LOC going down. So we have a GCS that's 15. So we're going to say this patient's times 4, right? GCS of 15. When the person, sometimes people skip these steps, but if we're going from fully conscious acting normally to in the presence of no sugar or no oxygen, it's usually in this order, though they might go through these steps very quickly, or when we arrive, they've already gone through some steps. But usually the first thing is going to be very much like your GCS score. They're going to be confused, right? Anxiety, though, is one of the first physical symptoms that we can see. So that happens with very small amounts of sugar being unavailable, or very small sets of hypoxia. After anxiety, the patient's likely going to start becoming more confused and disoriented. After anxiety, this patient might start getting agitated. So difference between anxiety and agitated is really in the physical response. So someone could have anxiety and not show agitation, and anxiety could be completely internal to them. But if they're showing being agitated, being physically, they're showing physical symptoms, that's the next step down. And then unfortunately, combative, their disorientation is going to continue. They'll become eventually lethargic, which means kind of sleepy. And then that can progress through steps to coma. So notice that combative is not very far down this list. And often when we arrive at somebody's home, when they're already hypoxic or hypoglycemic, if they're not unconscious, we might find them right before they go unconscious in that combative state. Now, these people aren't trying to in general, right? If somebody's experiencing this break in reality or this loss of mental status, they're not trying to hurt you because of you necessarily. They are suffering a condition in which their cerebral cortex, right, the main part of our brain for higher level thought that we generally attribute to being human. When we go back down to the core of the brain, there's an old brain, right? So the very basic responses of our vegetative brain, so close to the brainstem, that area is something that we share with other mammals. And in times of stress, especially when we're hypoxic or hypoglycemic, the person's brain no longer is thinking of things like we are right now. Instead, what happens is they're going to perceive whether something is a threat or not. And that's just going back to like the very basic animalistic function of preservation. So if somebody has a lack of oxygen, they become hypoxic, they're fighting you because when you walk up to them and you place a mask on their face, right, to give them oxygen to resolve this issue, they're not going to see that because they can't think through the process. They're not going to see that as help. They're going to see that as a threat. You're like putting your hands on them. Of course, an animal would consider that a threat. So they may respond as so. So you have to take extra time to make sure that we're communicating as well as we can with this patient. It may still mean that they're combative or they're stressed and fighting us in that sense. So then start, instead of with a mask on this patient and restraining them, maybe start with some blow-by oxygen, or maybe help control their breathing so you can get them to a point where it's not going to freak them out to put oxygen on their face. If they absolutely have to have the oxygen on their face, then do it, but realize it's going to use oxygen. The patient's going to use oxygen while they fight you and putting the mask on their face. That's kind of the idea. All right, and obviously chemical influences like drugs, alcohol can certainly cause breaks in reality. And then finally, because of certain electrolyte imbalances and the impact on the brain, we can have some of these things occur, including leading to patients' coma if they have an electrolyte imbalance. All right. So I'm going to let you read through some of these things. I want to get to the safety stuff. So ways you approach it. I've been pretty successful, but I have had to fight for my life multiple times, unfortunately. I've got plenty of stories on that, but I won't share them all right now. We've got to keep on track. But you hope you'll never have to be in that situation, but it may come that you will be in that situation. Okay. So things that you want to do aside from what I've already talked about. Be willing to retreat and have an evacuation plan as soon as you walk in the door, not later, because often it happens in just a spur of the moment. The person can switch like that and put your life in danger. Know where we have, when you're walking up to the house, the building, where do you have concealment versus cover? Actively look around. Make sure that your ambulance is facing out, so that that's to mean if you're going into a cul-de-sac, like there's a court at the end of the street, it doesn't go to an outlet. Before you go into the house and get down from the ambulance, you want to drive the ambulance by their house, turn around in the cul-de-sac, and then pull up with the nose of your ambulance facing your path of evacuation. Now, partly that's helpful so that when the patient's in the back, you don't have to do a whole lot of backing up, and puts people's life at risk. Unfortunately, there have been patients that have been run over by an ambulance backing up, or family members, not necessarily patients. And when doing so, if you have to evacuate, you're not going to have to drive down to the court, turn around, and drive by the house where maybe this person has a weapon, and now they've got another opportunity to get you, right? So think of those things in advance. Verbal judo, a couple things that you can just get quickly, but I encourage you to watch some verbal judo videos online. But the gist of it is, when you're speaking to somebody who's really, even if you're just arguing, like it's only verbal at this point, right? Always know that it can easily go into physical, but we want to calm them down if they're in verbal territory. And so we do so with our behavior. It's not about what we say necessarily. It's about how we say it and what we do. So when we're saying, how do we say it, what do we do? When you're communicating with somebody that's yelling to you, do not yell at them. Don't try to make this a shouting match where the person's higher octave, higher voice is the one that's the winner. No. Can very calmly communicate with them in normal language, and eventually they want something out of you. Usually they want, like, leave me alone. That's wanting something out of you. If they want something out of you, the theory is that if you speak in a normal tone, eventually they're going to have to calm down and listen to you, or at least stop yelling. But if you yell with them, you're going to make their situation worse, and it may progress to physical violence as well. It's kind of hard for me to show you these things, but I'm going to try and do it real quick for us as well. Your stance is important when you're communicating with people. Never have somebody standing above you, right? So that's a very bad position to be. Even think about like MMA and boxing. Some people, when they get on the ground, maybe they're great when they're boxers, but when they get on the ground, their ground game isn't very good, because it's really difficult to wrestle somebody, especially if you're underneath of them. Okay, so try and make sure that doesn't happen. Usually stand if you need to. It's okay to stand if they're sitting down for safety. If it's safe to do so and you get down to their level, like this picture has on the screen, that's always going to be a great situation of respect and rapport, but sometimes it's not safe to do that. Okay, so when you're standing, I'm going to hold this as my clipboard. Generally, you'll have hopefully a metal clipboard that you take on scene, and that's totally outdated, right? We have computers that we do our charting on in the ambulance today, but you still need something to write down notes on before you write your chart. You don't write the chart while you're caring for the patient usually. So I like to have a clipboard, especially a metal one, for this very reason, okay? So there's my clipboard, okay? So if I'm standing there and I'm writing, and the person tries to lunge at me, and let's say they're standing like right here, if I take my metal clipboard and I jab it under their nose, right, like right here, that's going to stop them so that I can retreat. Again, this is only so that I can save my life and retreat. It's not going to be offensive. It's only defensive. Okay. Also, when you're standing, I'm not sure if I could get this, but when you're standing, imagine, let's see, maybe you're going to want to see my chopos? You want to stand like this. Okay. If I'm facing the person towards, they're this way, I want to have this foot basically in line with, perpendicular. And then I want my front foot, my facing foot, to be pointing at that person. Why? If I'm standing flat foot like this and they push me, I'm going to lose my balance. So every patient interaction, you want to plant your opposite foot down on the ground, and then you're going to point your leading foot, whatever foot it is that's facing the patient, at them. And so when you're pushed, you have better sense of gravity. Okay, good stuff. Practice that. It's something that needs to be an unconscious habit. We're not teaching you that as like a skill in lab, as I understand, right? We generally don't have time to do things like that, but you need to practice this nonetheless. Another thing that you need to practice, you need to be in, when you're assigned to an ambulance, most agencies have ambulances that are very similar. So if we have 2 rescues, they're probably quite similar, might even be the exact same. Maybe there's an older rescue that's, a lot different, but it's in storage or whatever. When you get into a vehicle, you need to sit in that seat, whatever it is that you're usually going to be in. So an EMT is usually sitting in the driver's seat, and you want to just practice over and over again, pulling on the handle and opening the door. You want to do this when you first get into your truck, like, I'm not saying that you do this daily, but when you get assigned that vehicle, and if you get a new vehicle assigned, you need to do it all over again. But you want to do this, if you really want to get this down, hundreds of times. Because if you're in a new vehicle, and let's say this happens in law enforcement, unfortunately, if a cop gets a new cruiser and they're used to exiting their vehicle and it was a car, the handle is going to be in one position, but now they've got an SUV. The handle is going to be in a different position. So if they haven't sat to open their door handle over and over again in this new vehicle, when an emergency happens, their muscle memory, just like we're teaching you with your skills, their muscle memory is going to reach for where they're trained to open the door by repetitive, even if they didn't do it consciously. If they just keep opening that door, the brain's going to get the cue. So when you get in a new vehicle, you need to sit and practice that. Finally, this is more for your personal safety than it is necessarily for EMS, though it does happen that EMS agencies or ambulances are carjacked or stolen. If you have a weapon in your vehicle, a gun in your vehicle, I mean, I don't know why you wouldn't. It's Albuquerque. It's a very, very violent city, unfortunately. Carjackings do happen here. If you have that weapon in your vehicle, don't assume that when somebody tries to carjack you, just because you have a weapon in your vehicle, you're going to prevail. If you haven't practiced so that you have muscle memory in getting the weapon, brandishing the weapon, you're likely to get caught by surprise, and you won't have muscle memory to do the steps that you need to. So you're probably going to be in a worse situation than if you didn't have a weapon at all, meaning maybe the person can get the gun away from you that you brought to the scene in this car, your personal vehicle. Don't bring weapons on the ambulance. It's a violation of PRC law. All right, so those are little things that you want to consider. All right, so I want to jump ahead now. You're going to lots of stuff for you to read. Those are all important things. We're going to cover a couple of psychological causes, and one of them, I'm not going to do this for all of them, but you should on your own try to reach out there and find some videos of a day in the life of something. In this case, it's a day in the life of a schizophrenic. So here we go. I'm going to start our first video here. We're going to watch schizophrenia. Now, although this says types of schizophrenia, and in a moment I'll share the link to your chat so you can watch it on your own if you'd like, it's really not types of schizophrenia as I remember. It's basically looking at a morning in a person's life from their eyes. And so you're going to hear the way the person is thinking. We all have that internal commentary, but very often in schizophrenia, the person hears voices. So that's what you're going to hear in this, and you're going to see how they perceive things. Really very interesting stuff. Again, this will help us with our empathy in understanding what people are going through.
You are about to experience a brief simulation of a psychotic episode in a patient with schizophrenia. Schizophrenia can provide powerful experiences, especially for those undiagnosed or not being treated effectively enough. The symptoms you will experience represent a compilation of a range of sensory occurrences as reported by actual patients. These occurrences include sights, sounds, as well as wind and even scents. If you have any discomfort during the experience, please signal a facilitator.
Worthless.
He's waking up now.
Oh, the phone woke him up. Don't answer.
They'll know who you are.
You're a waste of space.
Why are you so stupid?
A waste of our time.
Stupid. So stupid. Worthless. We hate you.
He's gonna pick up the phone.
They'll know if you lie.
Rain! It's
Something
rain.
wrong. Weather.
Now to get pizza.
Poison.
Coming for you. Pizza.
He's hanging up.
Do you hear me?
Don't eat.
Out to get you.
Poison.
They know about you.
Cameras
Poison.
were rolling when the armed gunmen entered the convenience store on 14th Street. The suspects were described as medium in stature with a slightly youthful demeanor. Anyone with information about this incident is urged to contact
They know.
authorities.
They know about you.
And in other news, officials have closed the northbound
Time for
lane
meds.
on
Don't do
Boulevard
that.
due to a water main break. Repair crews are on the scene. Now here's a story out of Chicago from last night. Two men posing as maintenance workers nearly made it out of the Quick Bite convenience store with the store's ATM machine.
Make a
The
list.
suspects
Make a
pulled up in the
longer
van,
list.
entered the store, asked for
You
customers
are
to not use the
ungrateful.
machine because of
You're a
reported
waste of
problems.
space.
They
A
told
waste
the
of our
clerk that they were
time.
going to take the machine back to their
Getting
shop and
coffee
repair.
now.
Don't drink it.
Sensing something
Stupid.
suspicious,
So
the clerk
stupid.
That
called
smells
local
awful.
authorities.
Don't drink that coffee.
When the clerk told the men he had called police, the pair took off and left the machine.
Why are
in the
you so
parking lot.
worthless?
So Sky, tell us how this weekend's weather is
Weather.
turning out.
Something wrong.
You know what, Chuck? There's just no stopping the weekend weather. You hear that, Worthless? Weather's coming to get
Something
you.
wrong. Weather.
And what are you gonna do about it, huh?
Something wrong.
You have to stop it.
You're just gonna sit around with your stupid mouth open and do nothing?
You
Huh?
have to stop it. It's the weather. It's here for
Now
us.
he has to answer the door.
It's here for us. Do something. Stay in. Stay away from the
No,
door.
stop the weather. Protect us.
You didn't order anything.
No. Don't answer.
You're stupid to open that door.
He has to open the door now.
Here you go.
Don't do it.
You'll be in trouble.
Poison.
This is for you.
This is for you.
He's working with them. He's part of the plot.
This is for you.
Shut the door. Shut it.
Don't eat it. Poison.
You're stupid to open
I
it.
hate you. We
Here are
hate
some
you.
items on today's activities calendar. And you need some activities, especially when you're lazy and you sleep too much. Stop staring at me. I know what you're thinking.
He knows.
You can stop
They're
it.
coming for you. You know that.
Part of the plot.
Use your mind.
It's because you're so ungrateful.
Don't eat it. Poison.
No. Don't open
He
it.
has to open the
This
box.
is entirely your fault.
Don't eat it.
Don't eat it. Poison. Poison.
They're here, and it's all your fault.
Oh.
No.
They know it's you.
You're in
Don't
control.
open the door.
You hear that?
No. Don't open it.
Don't open it.
They're here, and it's all your fault.
You did it.
You should have used your mind to stop it.
Stop it. You have to take control.
Stop the door.
Hey, you all right in here? I called you. Why didn't you answer? I was like screaming, "It's Lorraine! It's Lorraine!" into the phone at the top of my lungs.
What were you watching? Do you even remember?
Did the pizza Oh, what happened here? Forget to take your medicine this morning. Well, you know it's not good to miss a dose. Well, it's not too late to take it now. Let's get back on track. And why are you standing here in the dark? It's a beautiful day outside. Let some sunlight in. You need to get outside and enjoy it.
This experience is intended to heighten your awareness of the conditions affecting breakthrough symptoms in patients with schizophrenia, who may be in need of efficacious treatments. It is not meant to suggest that all of the symptoms depicted here are displayed by all schizophrenics. There is no typical case of schizophrenia.
Okay, so in that video, it was meant to represent basically a person that has schizophrenia having a breakthrough. So when I've used that term a few times, the breakthrough. So what a breakthrough means is when somebody is treated for their mental illness, they sometimes will have breakthrough signs and symptoms. That's what we mean by it. And often that happens because they haven't taken their medication, as was shown in this video. Sometimes, though, it just happens because even though they're taking medications, there might be something going on in their life that stressed them a lot more than usual. And so the medication, it generally lessens symptoms. And unfortunately, we have a family member that has schizophrenia. Unfortunately, almost all the medications that he's been on result in him being sedated to a degree. And so they have a sedative effect, not sedated to where you like fall asleep all the time, but they'll be very tired and they're going to have less activity. So it leads to, for some people, especially with this disease and other mental health disorders, it leads to patients not taking their medication because they feel that the way they feel on the medication is worse than the way they feel when they aren't on the medication, right? And that's all perception. Some people experience that, some people do not. So what I want you to do for the exam now, for each of the disorders that we're going to talk about, let me get, the slide went a little different way. All right, there we go. For each of the disorders that's listed, I want you to know a few things about it. I'd like you to know what population of patient generally experiences these things. So for example, schizophrenia generally impacts, though not exclusively, but for the most part impacts young males. And so they might be diagnosed or have their schizophrenic signs and symptoms when they're in their teenage years, late teenage, early 20s. And then know what are some of the hallmarks of the patient's signs and symptoms. And so for schizophrenia, often they'll hear voices. When they hear voices, sometimes some people will, they'll hear voices and they'll attribute it to God speaking directly to them. That's somewhat common in schizophrenia, but hearing voices in general is really what's common there. And you don't necessarily have to know the treatment, but know that in almost all of the cases that we're going to read about in the textbook, almost all of them will have medications that can be used for therapy. And sometimes the medications are going to not only make the patients feel bad, but they often are dangerous medications as well. Let me give you an example of that. This isn't for schizophrenia. This would be for a patient that is experiencing and it's an older treatment, but though it still exists, but someone that's experiencing profound chronic depression might be put on something called a tricyclic antidepressant, a TCA, tricyclic antidepressant. The dangerous thing about that is when somebody overdoses on a tricyclic antidepressant, it generally results in cardiac arrest because it causes an arrhythmia, and the arrhythmia has a very specific name. It's called torsades de pointes. And so what it means is it looks like VTAC. It is VTAC, but instead of looking uniform like VTAC usually looks, let me draw a picture. If you see this, you definitely want to have ALS en route. But I had to restart my PowerPoint here. All right. So normally VTAC would look almost like a sine wave, right? Pretty regular. That's our QRS. There's no P wave. When somebody has torsades, it is VTAC, but they have this thing where they might have some variability where they turn the point. That's what it means in French. Torsades de point, turning the point. So notice how this is pointy here, and then this is pointy, and then the point goes here. And so you'll see even some variability in the height with torsades. And so think of this. They're prescribed a medication for their depression, which commonly does have a big risk for suicide ideations. They're prescribed a medication. If they overdose on this medication, they're probably going to die of cardiac arrest, but they're prescribed it as a treatment. So you can see that we don't always have great effects. No, this isn't on YouTube. This is the PowerPoint. All right, so we're going to watch another YouTube. I wanted to bring this slide up here, though. Don't forget that there are common causes for altered mentation. These are only two of the altered mentation. You're still seeing YouTube, huh? I'm sharing my screen here, so it shouldn't show. Maybe it froze. All right, let me hold on. Let's stand by. Why don't we take a 5-minute break and I'll figure out what's going on. If somebody's going to hang out behind, I'll just ask you to let me know when you see the PowerPoint. So let me stop the sharing. Go ahead and take 5, guys. I'll get this going. Let's see. Okay. Anybody see common causes slide? No.
Yes.
Has a picture of glucose? Yeah. Okay, cool. All right. So go ahead and take 5. It looks like we got it started for now, but please let me know because we're going to watch another video. If this happens again, I had to restart PowerPoint in the middle of that video because it froze on it. And then we'll go from there. So I'll see you guys in 5. All right, team. Let me just, while you're getting back, let me just point out, since you didn't see when I drew it, what I drew here. Okie dokie. All right, so this is supposed to be VTAC, right? And VTAC is one of our shockable rhythms. What ends up happening with torsades de pointe is the points change the direction. And so often you'll find that in some types of VTAC, we get these pointy parts, which is basically an R wave, right? The peak of the R wave of the QRS, because this is essentially a QRS right here. And so the pointy part is going to change pointing direction. And we have these variabilities in the amplitude as well. Some of these QRSs in VTAC will be the same height. Others, though, can be different heights. Still, though, this looks different than ventricular fibrillation, which has like no organization to it at all. It's just chaotic, right? There is a pattern here because this repeats. The turning of the points repeats. The amplitude's going to repeat. So if you look at this on the screen for about 6 seconds, you'll see a cycle. And note that in 6 seconds, this would be something like 200 or so beats per minute. So VTAC is a great concern. Now, we don't teach you that it's not a shockable rhythm. However, if you see this, you and somebody's overdosed on a medication, you need to get ALS there as soon as possible, because this person's going to basically go into cardiac arrest pretty quickly. Okay, so this is the slide I was mentioning. So again, common causes of altered mentation include hypoxia and low blood sugar level. I take for granted sometimes, though, that we do have something in our classrooms that I would refer to right now, and I don't think you've seen it. And so one of the tools we can use to identify common causes of, and maybe some of them not so common, but causes of altered mentation, there's an acronym for the types of things that can cause altered mentation. That acronym is AEIOU TIPS. Can you tell me if you've heard or seen that in any of your work? It might be in the lab classroom, to be honest with you, but I know that we're using different classrooms this term. Has anyone heard of AEIOU TIPS? Okay, good. So how will you use that? The idea is if somebody has altered mentation, you want to run through each of those things and ask yourself through your assessment, is this the cause? So again, to make sure that we don't get tunnel vision, meaning you don't want to have the bias where you walk in a room and you think somebody has X disease. And so you really only look for the signs and symptoms of X disease, in this case for their altered mentation. You don't want to get into that, but what you rather do is try and make sure it's not a bunch of things, and then you'll be narrowing it down to what this thing is. That's our rule out. Whatever we can't rule out, meaning whatever is left that we can't say is not present. I know it's a inverse logical idea, but whatever's left after we rule everything else out, that's the disease or the condition or the symptoms that we're treating. So what you should do is when a patient has altered mentation, and that could mean their GCS is 14, like they're by and large acting normally except for a small change, that likely indicates more changes are going to come. Their mentation is going to go down a bit. So think to yourself, okay, A, ask yourself whether or not it's likely that this patient is intoxicated with alcohol, right? E, environment or epilepsy. So is this person doing this because they're having a seizure? Remember, not all seizures are flopping around on the floor like a fish. Some seizures are very partial, some are focal. So that means that the only thing they do is they don't have physical shaking, but they will basically be disconnected from their brain in some way. We refer to that as the lights being on, but nobody's home. Their eyes are open, but they're not responding to you. That's a type of seizure. So there's a lot of different ways that can happen. Environmental means that when a person is hyperthermic or hypothermic, it does have an impact on their mentation. So you want to go through each of those and assess whether or not that's contributing. And it is common that patients have multiple things contributing to their altered mentation. For example, alcohol abuse happens in a lot of different groups in America. And so it could happen and does happen that patients that are diabetic are using alcohol, abusing alcohol, and that has an impact on their blood sugar. Whether or not they ate also can come from their altered mentation because of alcohol. So when a person is intoxicated and we smell alcohol in their breath and we see and they say, I've been drinking, a pint of vodka today, those things are helpful to paint the picture that this is an alcohol intoxication, but it doesn't mean that you aren't going to look for other causes, right? Because if they're intoxicated, if they have an altered mentation for any reason, we do have to question the reliability of their reporting, in the sense that we're going to, you'll still believe what they tell you, but you're going to confirm what they tell you. So if they say X, you're going to confirm that by assessing for the presence of X. Does that make some sense? So you want to check a blood sugar in a patient that's intoxicated in alcohol, whether or not they're diabetic, because some patients haven't been diagnosed yet. So that's kind of the idea. But the most common causes, AEIOU tips is basically all the causes. The most common causes are going to be associated with hypoxia and low blood sugar level. You'll probably, when you go back and review this, I don't know if it's jumping out at you right now, but when you next see that board in lab and in the textbook, I want you to think about how you're going to assess somebody for uremia, right? That's the U, uremia. Uremia is basically a toxic condition where their kidneys are not functioning, so they retain all of the waste. And the kidneys are a means of us getting rid of not just urine waste, but also acid. So when we urinate, we get rid of acid that's building up in our body. So patients that have uremia have urine, basically, it's not as it sounds, but the idea is there. They have the components that would be in urine circulating in their blood because their kidneys have failed. All right, so uremia is something that you'll assess their kidney function. And how do you do that? Ask about history, and hopefully somebody's there can answer, because their mentation is probably going to be altered for you. And then you're going to look for things like the presence of salts on their skin. When they sweat, they'll have a salt on their skin. They smell pretty bad because they're basically secreting the waste that would be in urine. They're secreting it in their sweat. Excuse me. And if they have renal disease, they're probably not going to the bathroom very often. So ask about their urination frequency and what it's like. And certainly your medication list might give you some ideas that this is a patient that has a chronic or acute renal failure. All right. But again, hypoxia, we can manage, right? We give the patient oxygen. Low blood sugar, we can manage. We give them sugar if their mentation allows us to do so, i.e. that they can follow commands of swallowing. So they're not going to aspirate on this. And if they can't take it orally, we certainly have resources that we can call ILS or ALS to come and bring that for IV administration. So a rule for your treatment, make a note here. I've mentioned this before. If you're assessing a patient and that patient has an abnormal mentation in any way, so maybe they're ANO times 3, right? They're not answering all 4 of the person, place, time, event questions correctly. Or maybe their GCS again is 14. When we have this present, we want to make sure that we always check a BGL in the primary assessment of a patient that has an altered mentation, even if we have no idea whether or not they're diabetic, because it's very common, and so common that we'll find that more often than not, altered mentation that can't be easily explained is often because of a blood sugar issue. So we're going to move our high value assessment of BGL to primary assessment when we are assessing a patient that has any altered mentation. Okay. If they don't have altered mentation when we're doing their primary assessment, you can leave it for your secondary, or you can do it later. But I do recommend every patient you should get a BGL on. It's just something that we do regardless of whether they're in trauma or medical. You want to have that picture. We just decide where we move it in our order of operation once we get to primary if they have altered mentation. All right, so you've already learned about stroke. You've already learned about some of the diseases physically of the brain. So that's kind of the organic underlying components. Then there's other things that can occur. Some of the conditions don't actually have a physical cause. They're purely the response of their brain, meaning it's not part of their brain that's malfunctioning when they have a psychological breakthrough. It's the way their brain works, not an area, but the way their brain works. So organic causes are going to be basically in the structure of the brain. These are metabolic causes. Obviously, we've got diabetic emergencies, electrolyte imbalances. There was a new radio show a while back well, a long while back when I think PlayStation or Xbox first came out, and they were doing a giveaway. I may have mentioned this already, but they're doing a giveaway, and the idea was someone came to the studio to compete so they could get win a new Xbox or PlayStation, whichever it was. And the challenge was they had to drink as much bottled water as possible, and whoever drank the most amount of water in the short amount of time would win it. Well, unfortunately, even though they were receiving calls on this radio station that was live. They were receiving calls from physicians, from nurses, from EMTs and paramedics saying, no, this is not a good idea. You can definitely hurt this patient if you continue this. And everybody laughed it off and said, oh yeah, water isn't going to hurt you. Well, in fact, one person died because of it. And that is because when you drink bottled water, it doesn't have any electrolytes in it, right? It's completely filtered out unless electrolytes have been added, and it will usually tell you that on the bottle. Most bottled water does not have any electrolytes in it. So what ends up happening is we put water with no electrolytes into our body, but our body needs water with salt, right? We generally get water with salt. We get that through eating and drinking. If you're drinking large volumes of bottled water, you're going to shift the way water works in your body, and water is going to leave your blood vessels when that occurs and go into your brain. And so what ended up happening to this patient, she had a seizure and she died with no history, no medical history whatsoever in her background. And the idea was that she had edema because of the electrolyte imbalances. Essentially, the brain is saltier than the water that they put in. So water is generally going to go where salt is. And so it goes into the brain and causes edema. We'll see that on the next slide. Organ failure can also be a metabolic cause in which the normal role of the organ is failing, and that leads to their altered mentation. So just my example of uremia is a very good example of that. And then finally, patients with chronic illness might have a combination of disorders and the medications they take that cause altered mentations. Here's a screen that's highlighting edema. So encephalitis is basically inflammation of your overall brain tissue. So this is usually happening in the cerebral cortex, the thing that you see here with the grooves and the peaks. Meningitis is inflammation of the meninges around the brain, right? So those are like the shrink wrap that goes around the brain. And then sepsis. We have introduced sepsis to you, but sepsis is something that is very, very complex and it takes a lot of background to truly understand. Sepsis means not necessarily that you have a blood infection, but that you have an infection that's basically causing inflammation in your entire body. And so in the presence of sepsis, often it's a type of shock. And so patients will have altered mentation because if we're talking about a type of shock, it means that we have inadequate cellular perfusion. That's the definition of shock. And so the result will be that their brain doesn't get enough oxygen and probably sugar, and waste is building up because of their dropping blood pressure, and the result is altered mentation. Okay, acute psychosis is really the proper term when we're talking about somebody that has broken with reality. Psychosis can have a number of kind of subclassifications within it though. And so on this list, mind-altering substances, and man, there's a lot of them, right? So technically, even caffeine is a mind-altering substance. Intense stress, delusional disorders. And so delusional disorders are, again, where they've broken with reality and they're kind of living in an alternate world in some ways in their brain. And then finally, schizophrenia is a list because unfortunately, we do find a lot of patients are schizophrenic, especially those, we'll find this as a high percentage of patients that are transient. So those that are homeless, living on the streets, a lot of times they don't have money, right? So they aren't going to be able to buy their medication. And so they're living with schizophrenia while they're in one of the hardest environments I think a person can live in. Imagine the homeless population today or last night, right? There will definitely be frostbite, and some patients are likely going to lose some of their digits, especially because this came on so quickly. All right, so that's as far as I really want to go on the individual disorders. You're going to have a list of disorders that you're going to review here. Let the PowerPoint slides be your primary study guide for this, to be honest with you, for the exam, and then fill in the dots when you're looking at the textbook. Okay, so I want to talk about one more behavioral emergency idea. So I'm going to cue this up as a video. So I'll take a little bit more time to make sure that it works with your help. Just a moment. The video we're going to watch, I'm going to put into your chat right now so that you can find it on your own. This is from Vice, a news network. Certainly, news has come into a lot of question recently about what's skewed or what's fake or all of those things. we're going to watch this because of the way they present the story, not necessarily because of the organization, if that makes sense. I think they did a pretty good job of presenting some of the facts here, but the more important part is how they extrapolate this to all EMS. So we're going to watch a video, not on the screen yet, just a moment. This video is of a situation that happened, I think, earlier this year, and it happened outside of Denver. On your screen, you should see like a big picture of, can't really make out, there's a building there, but it says Aurora, Colorado. How are we doing on that? Can we see that? Okay, good. And then hopefully we'll get sound. So we'll check that out in a minute. Okay, let me set the ground for this and why we're watching it. So this video is about, I think his name is Ahmaud Arbery. I may have misspoken there, but I believe that's who we're talking about here. And this case came up, although it happened before some of the things that we've been talking about in our social dilemma about the way law enforcement and the justice system interacts with people of color and minorities. It came out as a case that involved EMS and not just law enforcement. So I don't think I have to explain too much about the situation with law enforcement today. They're not well supported by the community because of a number of missteps, including deaths of patients and, well, they're not patients at that point, I guess, the death of people of color. And unfortunately, we get lumped into that, as I mentioned earlier, because some people just see us as part of the system, right? Like the man, we're just part of that system. Now, we're going to work with law enforcement often, and this is going to be mostly a video about paramedics, but the underlying moral of this is to realize that we have to make good patient decisions, and it's important that we are the patient's advocate. And that may mean that we have to go against what people on our team say. So an easy example to think of that's not as complex as this situation is to say that if you're in that case where we had a patient that was hallucinating and saw wolves and people were playing along with it, I did tell my paramedics, hey, we shouldn't do this. This is going to be dangerous. And I was driving, since I was an EMT, they were going to be in the back. And so they said, oh, we'll deal with it. But I think I could have been stronger as an advocate. And that means that sometimes you have to tell your partners, hey, this isn't the right way to do things. And it means that when you're asked to do something that's inappropriate for the patient, you're the last step. If you're the one that's going to have to do that skill, you're the last step that can, sound an alarm, put up a flag. So the background for this story is there was a gentleman that was walking down the street. I think it was late night. It was clearly cold up outside of Denver, and this person was wearing a ski mask. So this gentleman, as I remember the stories that I read, I kind of boned up on it recently by reading a few other stories. The idea was that this person did have a behavioral quirk about him. Not to say that it didn't list that he had a disease and the things that I was looking at, but he commonly was just his behavior was a little bit off. What we would probably say is someone acting weird. It wasn't egregious. So this person was walking down the street. It's a black male. I think he's in his early 20s and has a ski mask on because it's cold. And because of that, somebody called 911 and told law enforcement that somebody's walking around with a ski mask. Okay. So we're going to see where law enforcement gets on the scene and they go up and talk to the person. And then we're going to listen to the discussion that goes on through this. What I want you to take from this is we will work with law enforcement officers frequently, and we rely on them to do our job safely. And we use them for a number of things when they're on scene. Like we'll have them help us with compressions if we're shorthanded on a scene and police is there and somebody's in cardiac arrest. Generally, we do have law enforcement's back, and we all probably know, hopefully, that just like in EMS, there's bad apples. There are bad apples in law enforcement, but it doesn't mean that everybody is a bad apple. However, the institutional things that are in place already does mean that people that aren't bad apples may make some mistakes along this and mistreat our brothers and sisters of color. Okay, so in this case, there's the use of a drug called ketamine. Ketamine's not in your scope of practice. It is in the scope of practice for paramedics in New Mexico and nationwide. It's a drug that basically works by causing sedation and pain relief by changing in some ways the way your brain is going to have its brain signals working. And so it's something called synchronization. And the result of that is the person is going to be very heavily sedated, but likely awake in the low doses of this drug. Too much of this drug, though, is actually easy to overdose on. Too much of this drug is going to cause the patient to stop breathing, or at least depress their ventilatory rate, and it'll likely cause their blood vessels to dilate and change the airflow in their lungs. That's a result or side effects of this medication. Often when these patients are given ketamine, they hallucinate, and the hallucinations tend to be worse when they're coming off of the drug, when the drug is now kind of clearing out of their system and it's wearing off, in layman's terms. And so when that happens, often a paramedic actually has to give the patient another sedative, because the dissociation with reality and the hallucinations they'll experience when they're coming off of ketamine can lead them to be very combative and violent, okay? So in hindsight of this call, there was not really a reason for all of this to happen. And in the result, this patient died partly because of EMS's actions. All right. So let's just, I'll start playing it. I want to check on sound, and then I'll put my mute on and we'll watch it together.
Stop right there. Hey, stop right there.
How's that sound? Good? Okay, good. All right. So I'm gonna mute, and then we'll.
Stop. 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 I have a right to stop you because you're being suspicious. Turn around.
In July, Colorado's health department opened an investigation related to the death of Elijah McClain.
He's drawing up ketamine right now.
Okay.
They wanted to know why the 23-year-old had been given a large dose of ketamine before his death. The drug is a powerful sedative used by paramedics throughout the country. It's hard to know exactly how prevalent its use is because it's regulated differently from state to state, and there isn't much information sharing. But everywhere that it is used, it's supposed to only be used in specific cases. And victims who, unlike McClain, have lived to tell their story are starting to speak out about how it's being used more loosely than it should be. John Powell, who lives outside Minneapolis, was given ketamine during an arrest back in 2015. Powell was at the hospital visiting a relative who'd been shot when police apprehended him. Officers had received a complaint about a white or Hispanic man. Powell, who's black, didn't understand what was happening. Police say they mistook Powell's car keys for a gun and that he wasn't following orders.
I'm kicking on the door in the window trying to get my wife's attention. He called the paramedic over. He talked to him for maybe 2-3 minutes. The officer put his gloves on, opened the car door, grabbed my arm, I was handcuffed, pulled my arm out of the car. And the paramedic stuck it in my arm and pushed it in. He never even looked at my face. They said I was acting belligerent. I stopped breathing right away as soon as they shot me with it.
What happens when you wake up? What do you learn?
I see my wife sitting there crying, my kids, my mom, everybody sitting there crying. They ain't never left the hospital. The first time she seen me, I had all these tubes down my throat, and I was in a coma. We filed a lawsuit against the ambulance people. They paid me like $50,000, $60,000. I used that money to fight against the police.
A judge dismissed Powell's case, ruling that police had reason to stop him, didn't use excessive force when detaining him, and had no involvement in the decision to sedate him. It is technically on EMS to decide when ketamine is necessary, and since paramedics are the ones who administer drugs, not the police, it's hard for anyone to win a lawsuit against police for the use of drugs. But the relationship between paramedics and police officers is a tricky one. And there's evidence that police are doing more than just asking if the use of ketamine is necessary. In 2019, paramedic Joe Baker was called to a scene where he says police told him to give someone ketamine even though he didn't think it was medically necessary. He refused and says he was later forced to resign. He's now suing the department, which denies his account of what happened.
I didn't feel comfortable drawing up ketamine prematurely because I had not medically evaluated that patient. And the police officers were really frustrated with the fact that I wasn't going to go along with it. What ultimately resulted was I was placed on corrective action because I was insubordinate for not following the directives of the police officer.
Do you worry that police officers are instigating the use of ketamine more often than it should be used?
Police officers shouldn't be requesting it or suggesting it. I understand the situation that they're in where they may have an uncooperative individual that they have to deal with, but if the situation dictates that ketamine should be administered, then the paramedics are going to recognize that.
In Minneapolis, the Office of Police Conduct Review recently found multiple cases in which police had either requested the use of ketamine or were asked for their opinion, neither of which is supposed to happen. But it isn't just the overstepping of boundaries and expertise that's under scrutiny. The American Society of Anesthesiologists doesn't think ketamine or any sedative should be used in these situations as a law enforcement tool. Jamie Kennel, a professor and former paramedic, still thinks sedatives are useful and relatively safe, but he sees the issues too. When is a sedative like ketamine supposed to be used?
In this particular case, most systems reserve its use for the case of excited delirium, which is kind of a catch-all for acute agitation, unpredictable behavior that you're unable to often verbally de-escalate. A lot of the diagnosis is based on clinical impression, which is a vague, squishy science. As EMS agencies have to balance a number of things in order to choose appropriate drugs. In a sedative situation, they need something that can act quickly so that the patient remains safe and the crew remains safe.
Are certain groups of people more susceptible to excited delirium?
There's a social component on who gets diagnosed and who doesn't. And for the African-American community, especially for young males, there is a common stereotype of aggression, of violence. I think there's some evidence around overestimating weights, overestimating physical force that may suggest that members of this community are probably more likely to be sedated.
How has what happened to you affected your life?
Mentally, I'm still not stable. Every time I see police brutality on TV, I think about it. And it's like fresh in my mind. It don't leave you. I wanted to fight them regardless. If I didn't win, I didn't win. But I wasn't gonna not try. Because I know what they're doing to people is wrong.
Okay, so if you watched this and other forms of coverage on the subject of ketamine use, and if you just search Google, you're going to find tons of stories. The area that would be good to review if you wanted to review a little bit more on ketamine itself and chemical restraint, GEMS, the online EMS journal that we have, has a couple of good write-ups on it, but I included in the chat, I misspoke his name, Ahmad Arbery, I think is the gentleman in Georgia. So this guy, Elijah McClain, this kid, unfortunately, went from having, this is a moral dilemma, this is ethics, right? Because this kid went from having independence as a citizen of the United States, walking down the street, that's basically just doing what we're allotted in the liberty, the 14th Amendment of our Bill of Rights covers. So when we do these things, we actually are attacking patients' civil rights. And that's a big problem. So what we want to make sure from this story is you're going to be asked by law enforcement in your career as an EMT to take patients to the hospital that likely don't really need to go to the hospital. Or in this worst case scenario, do something to the patient based on law enforcement's recommendation. Now, a few things to think about this, okay? If law enforcement asks you to do something, so let's say that you're a paramedic and you did this, you gave ketamine at the request of law enforcement. If you did that and this case goes to court, you're not going to likely have any support. Law enforcement's going to say, hey, I suggested it. They're probably not going to put themselves at risk because they're going to likely lose their job if they do, as will the paramedic if found guilty. And so don't expect that they're going to support you in that right. Don't do it to appease law enforcement under any circumstances. We have the same goal. We should make sure that the community is safe. Both professions do that, but we have different ways of doing that. Law enforcement is going to do so through hopefully the use of justice and other means of getting patients or threats to be resolved. We're going to do so by caring for the patient's medical or traumatic event, okay, including psychological breakthroughs. This kid was not afforded his moral rights. Okay, so when he was arrested, whether or not they had probable cause is a different story for law enforcement, but he went from having autonomy, right, where he can make his own decisions because he is up until that point, when they put him on the ground and they were trying to subdue him, up until that point, he had displayed to the people in the case, in his family, that he was within normal mental capacity. So he should have been able to say yes or no, whether or not he wanted that medication. Now, when do we do things against patients' will? That's a very, very difficult place to be. And so we really want to be very careful when we take people or do things to patients against their wishes. And to do so puts us at significant risk of liability. So in this case, he went from being able to make his own decisions medically to suddenly having a drug given to him by a medical provider that didn't really have a basis in sound medical decision. And unfortunately, after he's been given this medication, he will have an altered mentation. So he no longer can make his own decisions. It would be similar to if you had a patient and they, at the intermediate level, you might be able to give a pain medication. Once you give a patient a pain medication, it's going to alter their mentation. Now they're your responsibility. So if we do something that takes away a patient's rights, we have to be extra careful because they're very vulnerable of those rights being broken. So this patient didn't have the right of autonomy, didn't have any type of consent afforded to that patient. And unfortunately, you see what the result is. He went from walking down the street to being in cardiac arrest. You saw that when they put him in the ambulance, they were doing chest compressions. You only do that if the heart stops. So he went from that as a progression of what that paramedic did. Now, you're liable for the lawsuit of that. And the gentleman that was shown from, Wisconsin, that gentleman's story, that paramedic probably lost their job since he was awarded a settlement fund. So you may not come out of your pocket, but your livelihood may be removed and you might not be hireable. And finally, they may take away your license. Worst case, you could be found guilty of manslaughter. You could be found guilty of actual crimes that don't have just penalties associated with them, but have time in jail. So when you're presented with a law enforcement officer who wants you to do something, and this will happen even though you can't give this medication, law enforcement has a different goal in that moment. So let me just spell the background for you and then we'll move on. So when a law enforcement officer is facing somebody who they're going to arrest, often patients or those people before they're patients, those individuals have what we call incarceritis. As soon as somebody finds out that they're going to be going to jail, there's no way around that. Often they'll have some type of medical emergency, and sometimes it's not actually realistic. They're faking it, right? So we get called to those things often, regardless of the medical condition of that patient. So we'll assess them, we'll check on them. One of the reasons law enforcement wants EMS to transport patients, sometimes they'll say to the patient without your involvement, like you will literally be standing right there as the lead EMT for this call. And the police officer might tell the patient, you're either going to jail or you're going with these guys. And in your mind, you're like, well, I don't need to take him to the hospital. Maybe he doesn't have a condition that warrants going to the hospital. But law enforcement will put that as a presentation because they don't want to take them to jail. And it's an unusual thing. This also happens when somebody has just enough of a medical condition that law enforcement believes the jail is going to refuse to intake that person. And so it does happen that when a person is delivered to jail when they're arrested, law enforcement will take them to jail. There's usually a clinic that has at least a paramedic and often a nurse that's working there, and they're going to evaluate the patient on intake, no matter what their condition is. So everybody gets a medical evaluation before they go in. If their medical condition is anything more than they can handle with their resources, now think of this, it's a medic and a nurse for a jail with hundreds of people in it, right? They'll be responding to emergencies as well, not just intake. So their resources are limited. So often when somebody is brought to them that needs medical care above what they can provide, and that might just be that they're so intoxicated, somebody has to sit and watch them, that's going to be denied. And the police officer is either going to have to call an ambulance to transport the patient to the hospital or take them to the hospital themselves. Now, further, what ends up happening, law enforcement doesn't like to do this, because if law enforcement takes somebody to jail and drops them off after the process, law enforcement officer goes back to the street and does their work, right? When they go to the hospital with a person that's in custody, they have to sit there with that patient the entire time. And so they won't be going back into the field, and they'll probably sit there well beyond their shift. So you can see there's incentives not to take the patient to the hospital by law enforcement. So often they'll throw that onto our shoulders. And it may be that there's lots of other reasons for this person or this law enforcement officer wanting you to take them to the hospital, but those are some of the common malaligned reasons. So in the presence of your medical care, it's appropriate to ask law enforcement to help you do things that they're trained to do. Law enforcement officers are trained to do CPR. It's appropriate to get information from law enforcement officers on things that they saw before you got involved. Maybe they've been in the crime scene and you haven't been in the crime scene, things of that nature. So interaction with law enforcement is going to be helpful for our decision-making. But again, we would violate our license if a law enforcement officer, and this was the pure reason you did this, asked you to do something to a patient that didn't have a medical underpinning. So you're basically malpracticing, right? You're violating the scope of practice. You're going to violate what your peers would do. So when it goes to a jury, somebody's going to testify against what you did because it's outside of our standard of care, all because you wanted to play on the team, okay? Now, not to say that we should be pitting ourselves against law enforcement by any means. I mean, we're on a similar team. However, their job is not medical. Even if they're medically trained, they can't give you orders because they're not a doctor. The only person in law enforcement that can give you a medical order is going to be a physician that might be on the APD's or the police agency's SWAT team. And even at that, they're probably a doctor that works in an ER. That's generally who takes those jobs. They may not necessarily be in a position to give you orders, right? They're not an MSEP at that point. If they give you an order, that physician has to go with you to the hospital. And you can see once you tell that physician that, same thing for a podiatrist who goes on a car scene and wants you to do something that's definitely not appropriate for the patient. A podiatrist would be a foot doctor. That person, if they're going to take over care, they have to go with you to the hospital and they have to tell the doctor and do the transfer, because a doctor can't transfer a patient to you, to I, necessarily, unless it's an interfacility transport, because for them it would be abandonment. Remember, abandonment is we have to transfer patients to level of our license and above, never below. So obviously any EMS level under physician would not qualify as appropriate. So those are the challenges that you're going to face in reality. These questions and this topic will not necessarily be on your exam. This is applied ethics in some ways. So think about the ethical principles that we've discussed and think about how your interpersonal communication skills are going to work with a law enforcement officer as an EMT basic, maybe a new EMT basic, but you're the highest trained person on a scene and law enforcement is there and they ask you to do something inappropriate. You need to have the courage to fight for that patient. Okay, even if they're in custody, if they are a criminal, if they're charged with a crime, any of those things applied, we still need to treat them as a patient, and our decisions can only come from being medically sound. Okay, I know it's hard, so I want you to think of this ahead of time because it will come up in your career. And sometimes law enforcement makes suggestions, but we don't act on them. And they're purely just a suggestion, especially as you get to know officers in the field, you'll build a rapport with them. And likely, as I did and many of my colleagues, they'll become friends of yours. Okay. So that's a challenge because you're telling a friend of yours, just like you would tell a paramedic making the wrong decision, I think something's bad's going to happen here. You need to have the courage to voice that. Okay. All right, let's rock and roll. I want to give you the environmental stuff. Environmental will be on the exam. In fact, I was going to give us a question here. Just one moment. I'm going to give us an example of a word problem style question that will, or a scenario style question that we'll have to answer on the exam. One moment. Okay, so I'm going to show you this question, and then I will verbally give you some answer choices, okay? So let me share. Okay, boom. Okay, you should just see it like a PowerPoint, not presentation, but just the editing side of a PowerPoint. It says click to add title. I just copied and pasted this question here for us. Okay, so a 66-year-old male patient presents with bizarre behavior. His daughter states that he did not seem to recognize her and was very rude to her. The patient is conscious and has a patent airway and adequate breathing. You should. So here's our answer choices. 1, conclude that the patient has Alzheimer's disease. 2, answer number 2, ask the daughter how her father normally behaves. Question number 3, carefully restrain the patient and transport at once. Answer number 4, advise the patient that his behavior is unacceptable. What would you say is the most appropriate? And let me read them just one more time, and I'd like you to pick one of those and just put it in the chat as what you think is the correct answer. 1, conclude that this patient has Alzheimer's disease and do nothing else. 2, ask the daughter how her father normally behaves. 3, carefully restrain the patient and transport at once. 4, advise the patient that his behavior is unacceptable. All right, so what would you choose? Excellent. Maybe you've seen this question before on a quiz. Good. So we have to understand a patient's baseline, because sometimes patients, I don't know that this patient's an older adult, but I don't know that I would say like extreme elderly age. As we get older, our brain isn't going to function as well, even if we don't have diseases like Alzheimer's. And so we have to understand what's a patient's normal behavior before we can determine what degree they're off from their normal behavior, if that makes sense. Okay, so that's the appropriate answer here. Let me talk about why the others wouldn't be an appropriate answer. 1, conclude that the patient has Alzheimer's disease. Though Alzheimer's disease can have some changes in behavior, and it may be that the person doesn't recognize a family member, Alzheimer's has other components that aren't listed here. So there's not enough information here to say that this is Alzheimer's by itself. The third answer, carefully restrain the patient and transport at once. So remember, if you restrain a patient, you're taking away their rights. You're doing so using legally the Emergency Transport Act of 1996. Please go back to your med legal section, the early stuff that we talked about in the beginning of the term, and find that, because there's 4 things that you have to do to transport somebody against their will. There's not enough information here to take away this patient's civil rights, to be honest. You need to do a more thorough assessment of their thinking ability, and then from there decide. And we couldn't transport it once, because one of the components of transporting somebody against their will is you have to get MSEP approval. There's no flexibility in that. If you can't reach a physician, you're going to have to try and reach that physician by some other means. It's not as easy a case in our scope of practice as anaphylaxis and epinephrine would be if you can't reach them. So you're taking a big risk if you even start transporting without talking to the doctor, with the intent that later when you have reception, you're going to call them. Now, you may have to do that. That might be a choice that you have to make, but we won't be transporting at once because there's other things we have to do in the meantime. Finally, he doesn't show us enough in this presentation of information that his life, his daughter's life, or our life is in danger somehow because of his behavior. And so when we transport somebody against their will and restrain them, it may be that they're not they don't have the mental capacity to make their own decisions and they need to go to the hospital for treatment. That's the basis of taking somebody to the hospital. But in that case, it might be that they're actually violent, might not be that they're violent, but we have to really have a good standing. And that standing is going to have to hold up in court, because these cases where we take somebody against their will are some of the second most common cases that go to court. The first are when we get refusals on patient care. Then finally, advise the patient that his behavior is unacceptable. Yeah, I mean, sometimes we do have to tell patients that they're behaving inappropriate. I'm not afraid to tell a patient when they're using poor language around children or just in general. I'll ask them to change the words that they're using. And if they don't, I'm not going to be able to restrain them because of that. But here, informing him that he's behaving inappropriately could be beneficial in that he doesn't realize he's doing it, but it isn't going to be a focus in our care. This is something that maybe you do just kind of off the cuff. All right, cool. Let's do environmental emergencies. Environmental emergencies is actually a pretty wide area. So on National Registry, I just want you to have the idea that even though in New Mexico we don't have great bodies of water, when you go through environmental emergencies, you're also going to talk about envenomations and interactions with animals. Please make sure that you're studying up on animals and environments that we won't see in New Mexico, because again, your National Registry exam, and so our exams as well, your National Registry exam is definitely going to ask questions about what do you do if somebody's in contact with a jellyfish, right? Been stung by a jellyfish. What do you do when somebody has drown in salt water. We don't have a lot of salt water here. So those are things that you still need to make a priority in your studying, because there will be questions on those things, okay? So make sure you've got that as a highlight before you take the exam, and obviously before National Registry. Okay, so this is going to involve environmental emergencies in the area of temperature. So experiencing patients that have high or low temperatures, aka hyper or hypothermia. And so thermoregulation we'll discuss. It's also going to include, aside from hypo and hyperthermia, we'll talk about things like drowning, saltwater and fresh drowning. There are some things that occur when we go to high altitude, we'll discuss. There's things that occur when we're deep under the ocean, and diving emergencies that can occur. And by the way, it's not as likely to happen, but there are jellyfish in New Mexico and people come into contact with them. Not generally everybody, but if somebody's working on working at the aquarium, there's jellyfish there, they could be stung. So it's not likely to happen very often, but it could still definitely happen. Do we have salt water in New Mexico that people might be diving through? Yes, we do, but generally it's indoors for research purposes. Doesn't mean though that somebody at a lab couldn't fall into that big pool of salt water and experience drowning. So it's a pretty wide area here, and you can definitely get sucked into the weeds. So I'm going to encourage you to, again, go by the slides here. There's a lot of them. I'm not going to cover them all, but the slides should be your primary sense of focus for this. So let's talk about thermoregulation to start. Thermoregulation is a problem in which the person well, let me back up even further. I'm going to tell you how it happens normally, like what thermoregulation does normally, and then we're going to apply that to hyper and hypothermia, okay? So this picture here is showing a cross-section of the cranium, and we're showing within it a cross-section of the brain. And in this box that we have zoomed in, we're seeing basically the brainstem, okay? So back to our anatomy for the nervous system. This is the brainstem. This is the pons. The midbrain is basically what physically connects to the rest of the cortex from the brainstem. And then down here would be the medulla oblongata. So that's below the pons. Now the pons, as a reminder, is an area where we have some of our basic vital signs controlled, but primarily it's controlling things like breathing. We have in our medulla oblongata our control of our cardiovascular. So a little bit below the pons, not necessarily in this picture, is where that will occur. So expect that when patients have pressure building up in the cranium, just like we talked about with the stroke, it can put pressure first here and then puts pressure on the brainstem. And that's how we get all those signs and symptoms of patients. We're going to review that when we get to the head injury. So that's the orientation of what we're looking at. Now for thermoregulation, we're going to zoom in just to the hypothalamus, okay? So we have a thalamus and we have a hypothalamus. Hypothalamus either means low or in this case below. So the hypothalamus is an extension of our thalamus that then connects integrated with our midbrain and then communicates through the nerves, both receiving signals up and sending signals down to cause an effect on organs or skeletal muscle or the like, okay? The pituitary gland is encased in the bone and it's an extension of the hypothalamus, okay? That's part of our endocrine system. The pituitary gland is the master gland. And so it does actually have an interaction when we're talking about thermoregulation. How does that work? Well, when the body says we're cold, and it sends a signal to our body to increase our body temperature. Some of that's going to be through physical behavior, right? Like if you're cold, you're going to have the thought of putting on something that's warm or turning on a heater. So those things aside, your body also has mechanisms. What it does, let's say that the patient's cold, the hypothalamus is sensing that by measuring core body temperature. So that's basically the temperature of blood in the main organ area. The temperature of our blood in the extremities, at the surface of our skin, is going to be different than the core body temperature in some cases. So it's sensing the core body temperature. I want you to imagine, though in New Mexico this isn't always the case, you're going to imagine for the normal use of this hypothalamus that you have a thermostat. Okay, so it's set to 98.6 degrees Fahrenheit. And on this thermostat, let's assume that it's not like a swamp cooler control. If you have a swamp cooler in your house, you probably have a control for the heater and a control for the swamp cooler. But if you have a combo unit, like you would find at C&M in the school, that unit is one unit that can provide heat or provide air conditioning. Okay, that's the thought we have here. This is how we're going to understand it. So let's say that we have our temperature, our thermostat set to 98.6 degrees normally, okay? So the body then is going to do things around that temperature setting, meaning that if the sensing, like the thermometer in our body, senses that our body temperature is 96 degrees, not 98.6. And that's where it's set normally, 98.6. If it's at 96, then the body's going to turn on its heating mechanisms, cause some things to happen in the body and probably your behavior. And then it brings the temperature up and it stops heating once we get to 98.6 degrees. Okay. Just like we would have in a house with an air conditioner heater. Likewise, if the person doesn't have a fever, put that in its own box. But let's say the patient's outside in the heat and their body temperature is rising because of that. Then if, again, our thermostat is set to 98.6 degrees, then once it goes above that, the body's going to turn on the air conditioner. Okay, so I'm going to say cooling is one route and heat is another route. Okay, so they both stop. And this is something that's called a negative feedback loop. Negative feedback loop, okay? Negative feedback loop means that we have a sort of stimuli to a process, then a process occurs based on that stimuli, and it stops, it's negated, it stops once it reaches a certain point. That's different than a positive feedback loop. Positive feedback loop doesn't, it responds to stimulus, yes, it is a process, but what ends up happening in the positive feedback loop is this thing is going to amplify until there's nothing left. So it'll just keep going until nothing is available for it to work on. It's not a switch. So negative feedback loops are the most abundant type of feedback loops that we have in the body. Thermoregulation is a very good example of that, meaning that when we have our thermostat set to 98.6 degrees, if the person's body temperature goes up, it's not going to keep cooling forever. Right? It'll only cool until we get right back to what our thermostat is set to. Now, I keep saying thermostat set because when we have a fever, our body changes the thermostat in the hypothalamus and it resets it to say, we'll allow the body's core temperature to go higher than normal. So imagine it's resetting our body thermostat. I mean, this is kind of imaginary and personification of a structure, but when it does so, it's now going to allow the body to heat to levels, say 104. So if this patient's now thermostat is set to 104, the body is going to now see that if our core body temperature is 98.6 at that moment and we turned it up to 104, technically we're cold. So the body, even if we're in a heated environment, the body is going to turn on the heating mechanism to try and get the temperature back to what that thermostat was set at, 104 degrees. Now, certainly that happens for a lot of reasons and can go off the rails, which is why we have medications for febrile-based seizures. But the idea is that our body can change this and set it, and will experience changes based on that new thermostat setting. Let's say that you had a fever. We've all had a fever, likely. You have a fever, you are taking medications, and let's say overnight, while you're asleep, your fever breaks. When you wake up the next morning, what do you feel? What's your body like if the fever's broken? Well, you're probably drenched in sweat. Why is that? Well, once the body says, okay, we accomplished our mission, or we turn off through medications, the thermoregulation mechanism, then our body's suddenly setting our thermostat from 104 back to 98.6 degrees. So if our core body temperature is 104 at that moment, then it's going to have to cool to get back down to 98.6 degrees. What's an effective cooling mechanism? Sweating. And so when a fever is broken, often you'll experience that you're full of sweat. That's the cooling mechanism of your body working, because now we reset the thermostat. It's too warm in here now, even though previously it was allowed. So that's the normal response of thermoregulation. So what ends up happening in this process? Well, we already talked a little bit about the cooling mechanism, and both of them are negative feedback loops. But the cooling mechanism is going to do things like cause vasodilation. So more heat, more of your blood is going to pass by the surface of your skin because our peripheral blood vessel is vasodilated. That allows for heat to leave our body through multiple mechanisms. One of them is conduction. It's just kind of leaving and exchanging heat from the surface of our skin, and it's getting transferred to the air around our body. When we have this occurring, we can also sweat. So sweat is another primary mechanism of thermoregulation, especially the cooling route. When we sweat, when we sweat, we're basically going through evaporative cooling. Come on now, play nice. Play nice. Sorry. Okay. So in that process, evaporative cooling is like our swamp cooler. It utilizes water to take the heat out of our blood vessels, essentially on the surface of our skin. It's absorbing our body heat, and then water can hold on to temperature. It absorbs heat at a much higher rate than just air does. And so then that water evaporates, releasing the heat into the outside environment. If we need to heat ourselves up, then we'll find vasoconstriction. Sorry, my handwriting's terrible on this device, but vasoconstriction, meaning we take the blood and we shunt it to our core so that our core organs can experience the right body temperature and we won't be losing it to the outside environment. Because if we're in a cold environment and the blood is passing to our surface of our skin through vasodilation, then we're going to lose more heat than we need to, leading likely to hypothermia. In addition, or essentially the mechanism that we get this heat, in addition to vasoconstriction, is going to create more heat by doing more work. So that means that we experience things like shivering, right? When a patient shivers, they're having micro portions of their skeletal muscle contract, not in a coordinated way. We've all experienced shivering. What it's doing is it's asking those cells individually just to do work, not to move, but just to do work so that we create heat. The process of creating energy has a byproduct of heat in that creation. So the body's going to do that by asking the pituitary gland to send a hormone to our thyroid to increase the metabolic rate. That's the idea. Now, I think we've already explored the area of diseases like hypo and hyperthyroidism. So with hyperthyroidism, the person's likely creating a lot of this hormone that will ask their body temperature to go up. So they have a higher metabolic rate than somebody that's normal, or hypothyroid. Hypothyroid means that they have less mechanisms creating energy. So they're often very cold. Hyperthyroid, they're very often very warm. All right, so these mechanisms here, I'll let you review. These are all the mechanisms that are involved in changing core body temperature. Let's see, there's that. Know these 4 things, be able to give examples of them. These are the way that heat is transferred in and out of the body. I'll let you review them. Wind chill chart, this is just an expression of the convection process. So convection, if you have a convection oven, you have better functioning ovens if they're conventional ovens, because in addition to heating the air, it also cycles the air around the heat or around the food that you're cooking, and that will make the food cook more evenly and faster. So that's the same idea when we're talking about wind chill. So when we have a person, let's imagine this young lady's not fully clothed, like maybe her arms are exposed to the cold environment. When we have cold air and wind, that's worse than even lower temperatures of cold air with no wind. The reason is if we're having just cold temperatures and no wind, then we're likely experiencing something like radiation or conduction of that out of the body. But when we add air, the air that's absorbing the body temperature's heat, it's colder, obviously, right? So the air is cold. When it goes by, when it's windy, it replaces the air around our body that's absorbing that heat with fresh cold air. Because if we were just radiating and conducting heat out of our body and there wasn't any wind, the air around our body is going to warm up, right? And the difference between our skin temperature and the temperature around us of the air is going to dictate how quickly we lose heat. So if we're 98.6 degrees on our surface of our skin and suddenly we're in a cold environment that's like, say, 32 degrees, like freezing, like as we've experienced the last day or so, when we have that occur, the body will heat the air nearby. And if there's a big difference, more heat will leave the body. So if the person's experiencing 98.6 degree skin temperature, and then they're experiencing air that's like 60 degrees, they'll lose some heat, but the difference is not as big as 32 degrees. So they lose less of it when the temperature is a slight difference. Okay. So what ends up happening is the wind keeps bringing fresh cold air and evacuating the air that we warmed up that would normally provide a little bit of a cushion around our body. And so we lose that heat because cold temperatures are being continuously supplied. That's the idea behind the wind chill. So this chart, you don't have to memorize, you don't have to understand the calculations that are here, but it highlights on the x-axis what our temperature is of the air that's around us. And then it shows on the y-axis the wind speed. And the numbers that are inside the chart are basically going to be the numbers that it feels like. So you've all seen on your phone or on the news when they talk about temperatures, they'll say this is the temperature and it feels like this. So this is essentially what they're referring to. If it's a cold, windy day compared to a day that's not windy, but they have the exact same cold temperature, it will feel colder because of the wind removing heat from your body more quickly. Also in the color series, you see how long does it take for somebody, if they have wind chill at a certain temperature, to experience frostbite. And frostbite is in which our tissue freezes, our soft tissue freezes, and the cells destroy themselves or die because of it, because when water freezes, which is heavily abundant in our cells, water expands. And so when it freezes, it's going to expand our cells and break them open, and that tissue dies. So let's just quickly look at what this chart is telling us, and then we'll move on. So this is saying that if we have an ambient temperature of 15 degrees Fahrenheit, and we're experiencing 5 miles an hour of wind, then it's going to be effectively 7 degrees of a temperature experience. It's going to feel like 7 degrees. And the feeling is important. It's not just that it's psychological. That's literally how quickly you're going to be losing or the temperature that you're experiencing on the surface of your skin. So if we look at somebody that has been exposed to 0 degrees Fahrenheit, and we have wind at about 25 miles an hour, they're now experiencing negative 24 degrees on the surface of their skin. And in this color here, it'll take 30 minutes of exposure without clothing and stuff on. So think like nose, fingers, all of those areas. Within 30 minutes, they'll experience frostbite. And then in some areas, I mean, if the colder it gets and the windier it gets, the more we experience and the less time it is for that. So wind chill is associated with convection. Then finally, we have evaporation here as a means generally of cooling. But remember that if we're wet in cold environments, we're going to, whether it's sweat or water, we're going to lose heat more readily because water absorbs heat at a much higher rate. This is what explains the idea of if somebody falls into a body of water that's really cold, they're going to experience hypothermia much faster, even if the water and the ambient air around the water is the same temperature, because water has a higher absorption rate of heat. And so the patient will experience hypothermia, frostbite, all of those things more quickly. Respiration is noted here. It isn't the 4 mechanisms of changes in body heat, but it is a reminder that when we're breathing, we're losing heated air out of our lungs and water, because when we exhale, that air is humidified. So we lose water and temperature by ventilation. You know this is true because if you have exhaled on a cold pane of glass, your warm, water-filled or high humidity breath makes condensation on the surface of the glass, and you can write your heart mom or whatever it is that you want to put on that, okay? So remember that our respiratory tract is an effective heat exchanger. If we are able to give a patient warmed oxygen as compared to cold oxygen, we'll be able to warm that patient faster, and it's warming from the inside of their body out versus us trying to warm from the outside of the body in. Now, we don't really have heaters for our oxygen tanks, but you should be aware that oxygen in our tanks by itself is colder than normal and drier than normal. And often on the ambulance, the main oxygen tank is on the outside of the ambulance. It's in a compartment that's basically at the edge of the box that we're in. So it's going to get even cooler as it goes through that. So we may want to humidify the oxygen in the case of this, because what it can do is the humidity is going to take some of the heat that the body exchanges to that water as the person breathes it in. It's going to be colder than their internal temperature. And that heat will transfer back down into their lungs when they're inhaling. And unfortunately, some of it will leave when they're exhaling. And then finally, radiation is just loss of this heat radiating to the environment. The heat index is kind of like our wind chill. So heat index is not based on necessarily the rate of wind moving by our body, but it's speaking to what happens when the air is very humid. Again, when we're dealing with water, water has a higher rate of absorbing heat than air does. So somebody that's in a hot environment in New Mexico, where our relative humidity is usually really, really low, then that person's going to have a slower route to hyperthermia or a heat emergency than somebody who's working, say, in Houston, Texas, where humidity is really high in the same ambient air temperature. Because what happens is if we have a lot of humidity, water is going to condense on our skin, and it's in addition to our evaporation, our sweating. And when that water attaches to our skin, it already has the high temperature of the environment. And so the process is that heat, since our body will be colder our body will be colder than the heat that we have external, then the temperature is going to come from the already heated water and go into the body, and that leads to overheating. So it's worse to be in a hot environment that's humid than it is to be in a hot environment that's dry. Again, this will not be as a chart on the exam. It's just kind of highlighting the index. So you can see here when heat stroke and other heat emergencies will occur at different rates and humidity. And usually we're not even in the 40% relative humidity in New Mexico. So for your practice, we won't see a whole lot of this, but certainly it'll be a test question on National Registry. So because of that water, the body can't cool itself through evaporation, even when they're sweating. So really what they're doing at that point is just losing water out of their body. So it leads to dehydration. It doesn't help them with the mechanisms of cooling. History concerns, these are some of the things that you'll want to explore in patients with a heat emergency or a cold emergency in your sample questions. So alcohol use and drug use usually makes our thermoregulation ineffective, not as effective as it normally would be. So that could mean that it makes the person susceptible. So someone who's on a medication maybe doesn't have an awareness that it's cold outside, or through age. Very old or very young patients don't sense heat the same way, and they don't cool or warm themselves up the same way as someone like our age range would. So a good example of that is when a patient, an elderly let me rephrase this. When you're going to visit grandma or grandpa or an older person in your life, you note that even in the summer, sometimes they are under blankets or under a sweater. That's because they're not sensing the temperature in the room appropriately, and they think it's artificially cold. So they put all these layers on and they feel warm. But unfortunately, that's making their core body temperature go up, and they could suffer a heat emergency. Likewise, another example for children. As a child, you were probably told when you go outside on a day like today, you need to have something on your head to prevent heat loss, because the surface area of a child's head, especially a small child, the surface area of their head is proportionately much larger than the surface area of their body. So they'll lose a lot of body heat out of their head because there's just so much surface area compared to their height and extremities. So when a child is born, when we go through the process of delivery, we want to make sure that we put not just the child into a bunch of bundle of blankets after they're delivered and cleaned. We want to put a little stocking. In fact, it comes in your OB kit. In the lab class that you have, if you look at your OB kit, it likely has a little beanie for that baby. And so the idea is that child just came out of a very warm environment. They don't have the mechanisms they need to warm themselves up. For example, shivering won't be as effective. If they're too hot, they don't sweat very well. So they're at high risk of having these heat or cold emergencies. Let's see, just like medications or drugs, they're all chemicals that change the body. We can find that prescribed medications can change the way that somebody experiences dehydration, experiences heat or cold temperature. And then diseases themselves can have an impact. As mentioned, hypothyroidism is going to have an impact on the patient's ability to manage their internal temperature. Because with hypothyroidism, they're getting a signal to have less metabolism. People that have hypothyroidism will generally be a little bit more in weight gain than somebody who has hyperthyroid. They're generally less weight. They usually are thinner. And because of that low metabolic rate, they're not creating the normal amount of energy they would need to get to the point of 98.6 degrees Fahrenheit. So even in a room that's got a normal temperature, their underlying body temperature might be lower than normal. Probably not too much lower, because then our body will probably turn some mechanism on. When somebody gets really, really hot, sweating becomes ineffective, even in environments that are dry. And when someone becomes very, very cold, their shivering mechanism of creating heat becomes ineffective as well. So we have to realize that they can't rely on their body to adjust these temperatures. It's completely on us to do so. All right, so hypothermia. Hypothermia is the body's temperature going below 98.6 degrees Fahrenheit. Here's some tricks for you on the exam. For hypothermia and hyperthermia, you're going to be presented with different levels, ranging from mild to severe, though in heat, we have a different way of terming. It's the same idea, though. We go from less heat absorption to higher heat absorption. We just use a different scale. On in the process of hypothermia and hyperthermia, we're going to say that there's signs and symptoms and temperatures with each of these steps, okay? Now, I'm more concerned with you understanding things like the signs and symptoms and not necessarily body temperature, because body temperature might not be reliable when we're taking it on somebody who's extreme in one of those areas. And we're only taking external temperature, so we don't get core body temperature, which is what's going to present it to you. And finally, sometimes we don't even have a thermometer that works on the ambulance. I know, it's New Mexico, it's what we do, right? So in the normal mechanism, I want you to realize, what does the body do when it's normally cold? So understand that process. What does the body do when it's normally warm? Understand the cooling process. And then these are going to be changes in that. Essentially, their body can't keep up with it. And finally, for both heat emergencies and cold emergencies, there's a point at which the person crosses over and their mentation is going to change. Generally, their mentation changing is the signal that they're moving from a lower to a severe level in both of these cases, okay? Those are the big things to know. I encourage you to make a chart that kind of highlights these things and compares them side by side. There's one in either your book or the PowerPoint slides here, but still making it, drawing it, using your hands to physically make a chart is going to help you remember things more clearly, especially if you're a hands-on learner. Trust me, it works, even though it seems like you wouldn't.